Okay, let's unpack this. Imagine you're preparing for a medical procedure, maybe something relatively routine.
Right.
You might be focused on the surgery itself, but what about all the crucial steps that happen before you even get to the operating room?
Yeah, there's a whole process.
This deep dive is all about medical management and preoperative patient assessment.
Mhm.
It's a critical, often unseen foundation of modern medicine that directly impacts your safety and, well, your optimal outcome.
What's truly fascinating here is how this meticulous, systematic approach to a patient's overall health before any intervention isn't just about ticking boxes.
Right, it's more than a checklist.
It's about uncovering hidden risks, spotting subtle clues, and proactively minimizing potential dangers to guide the most effective treatment.
So it's like preventative maintenance for surgery.
In a way, yeah. We're going to explore how medical professionals transform a patient's entire medical history, stacks of records sometimes, into a precise roadmap for care, preparing them for surgery. 1. The foundation. Why preoperative assessment matters.
We're often thinking about oral and maxillofacial surgery patients who can be relatively young and healthy, making major medical complications feel, well, uncommon.
That's often the case, yeah.
But here's where it gets really interesting. A comprehensive preoperative assessment is absolutely vital because it can uncover existing medical conditions a patient didn't even know they had,
Exactly. It's like finding a hidden pothole in the road before the car hits it.
allowing us to patch it up or navigate around it safely.
Precisely. This proactive identification provides clear guidelines for management and allows patients to be stratified by surgical risk.
Because the human body is incredibly complex.
It really is.
Yeah.
A thorough medical and social history is the first crucial step for eliciting known comorbidities. Think of it as a detailed interview.
Getting the full story.
Then a physical examination complements this, often confirming or even identifying systemic diseases that were previously unrecognized.
Ah, so the exam builds on the history.
Right. This systematic approach looks at everything from a patient's chief complaint to a review of all their body systems, allergies, medications, social history, family history, surgical history, functional status, the whole 9 yards.
You really cannot underestimate how powerful a well-taken history is in flagging an unrecognized medical condition.
It's foundational.
So the physical exam isn't just a routine check, it's a targeted investigation based on that initial history, designed to identify specific positive and negative findings, which then guide whether further investigations or referrals are needed.
That's right. The ultimate goal here is to identify those medical concerns and then provide the most efficacious, the most effective perioperative treatment to minimize any patient morbidity.
Which means understanding both the surgery and the patient.
Absolutely. You have to understand the stress of the surgical procedure itself and the patient's individual medical condition. For instance, more involved head and neck surgeries are typically considered intermediate risk, while a routine oral and maxillofacial procedure in an office setting is often low risk.
Gotcha. So when we talk about assessing surgical risk, there are a couple of primary classification systems that healthcare providers use, kind of like shorthand.
Exactly. Quick ways to get a sense of a patient's overall health burden. One of the most common is the American Society of Anesthesiologists, or ASA, Physical Status Classification.
ASA class.
Yeah. Instead of memorizing every class, think of it as a spectrum. At one end, ASA Class 1 is a perfectly healthy patient, no systemic disease.
Simple enough.
As you move up the scale to Class 2 or 3, you're talking about patients with mild to severe systemic diseases that might limit their function in some way.
Okay, so increasing burden.
Right. And at the furthest end, Class 4 and V, you have patients with severe, life-threatening conditions, or who are considered moribund, basically not expected to survive without the operation.
That paints a clear picture.
And this classification is often combined with another important tool, the Duke Activity Status Index.
Duke. What does that measure?
It helps us gauge a patient's functional status using what we call metabolic equivalents, or METs.
METs, like exercise levels.
Sort of, yeah. It's a practical way to understand how much energy a patient can exert. For example, if someone struggles just walking around their house, that's a very low ME score, maybe 1 or 2. Indicates poor functional capacity.
Okay.
But if they can run or play strenuous sports, they have excellent capacity, maybe 8 METs or more.
So it's about what they can do.
Exactly. And this raises an important point. While age alone isn't a great risk indicator, it serves to further refine our assessment when combined with these classifications, especially in very elderly patients who might have reduced reserves, even if they look okay on paper. 2. Deep dive, cardiovascular assessment and disease.
The heart, obviously central to everything, and cardiovascular disease is such a broad category.
Huge. And its presence significantly correlates with perioperative risk.
So how do we tackle that?
Well, beyond the standard history and physical, looking at the patient's specific risk factors for cardiovascular disease gives us valuable insight into potential cardiac complications during and after surgery.
Makes sense. Are there specific tools for that?
Yeah, early systems like the Goldman Index back in '77 and its Detsky modification in '86 tried to quantify this. They stratified patients by total scores based on risk factors.
Oh, interesting. Like points for different conditions.
Exactly. And they showed a clear relationship. Higher scores meant increased risk of serious complications. For instance, a heart attack less than 6 months ago, unstable angina, or severe heart failure within a week each carried significant weight, like 10 points in Detsky's system.
Wow, okay. What about now?
More recently, the American College of Cardiology and American Heart Association, the ACCHA, have provided updated recommendations. They categorize patients into major, intermediate, or minor clinical predictors.
Clinical predictors. So signs and symptoms?
And history, yes. This helps guide immediate action. If a patient has major predictors, think acute coronary syndromes, decompensated heart failure, severe valve disease, elective surgery is simply not recommended. The risks are just too high.
Right. Stop and fix the heart first.
Essentially. For intermediate predictors like maybe mild angina, a prior heart attack, but stable now, compensated CHF, diabetes, or minor predictors like advanced age, an abnormal ECG, low functional capacity.
That's where the functional assessment comes in again, the METs.
Precisely. What's fascinating here is how, for those intermediate and minor predictor groups, a careful assessment of functional status using the Duke criteria, the METs, is absolutely crucial.
Why so crucial?
If a patient has poor functional status, less than 4 METs, that's a big red flag.
Okay.
We need to send them for non-invasive cardiac testing, often stress test, maybe exercise echo.
To see how the heart handles stress.
Exactly. And if those tests identify high-risk findings, then we might even need to consider coronary angiography, looking directly at the heart arteries before any non-cardiac surgery. It's all about making sure the heart can handle the upcoming surgical stress.
Got it. And you mentioned the heart's workload. It's influenced by 4 key factors.
Right. Heart rate, preload, that's how much blood fills the ventricle at rest after load, the resistance the heart pumps against, and contractility, how strongly it pumps.
And understanding these helps manage the heart during surgery.
Yes, clinicians can modulate these factors to influence myocardial oxygen demand.
Okay, let's break down some specific conditions. Coronary artery disease, CAD.
Very common. Patients often have a history that points to it, with those classic risk factors. Diabetes, hypertension, smoking, high cholesterol, family history.
And it can show up differently.
Yeah, it can manifest as stable angina, chest pain with exertion, or more acutely as an acute coronary syndrome that's unstable angina, or a full-blown heart attack, an MI.
What's the difference in acute syndromes?
The key difference is that symptoms might occur with less exertion, or even at rest, and they're not easily relieved by rest or nitrates like stable angina often is.
Okay, diagnosis. ECG.
Diagnosis is often supported by a 12-lead ECG looking for characteristic changes like ST elevation or depression, T-wave inversions, Q waves, and also elevated cardiac enzymes in the blood like CKMB and especially troponins.
And if it is an acute coronary syndrome?
Initial treatment is rapid. Oxygen, sublingual nitrates, morphine for pain, and 325 milligrams sublingual aspirin, often followed quickly by other treatments like heparin or beta blockers.
You mentioned beta blockers. Are they used routinely now?
Yeah, perioperative beta blockers have been shown in studies to significantly reduce cardiac events, which is a major win for patient safety. It's become quite standard for at-risk patients.
That's good to know. And the timing after a heart attack, you said that's changed.
It really has. Historically, we'd avoid elective surgery for a full 6 months post-MI.
Wow, 6 months.
But with modern interventions like stents and better medications, that waiting period is often much shorter now, perhaps down to 6 weeks, depending on the specifics of the MI and the patient's recovery.
Okay, big shift. Next, congestive heart failure, CHF. The heart's not pumping effectively.
Right. And the distinction between compensated and decompensated is critical. Compensated CHF, where the body is managing, is an intermediate predictor for surgery.
Manageable risk.
But decompensated CHF, where the patient is acutely fluid overloaded or symptomatic, that's a major predictor and an absolute contraindication to elective surgery.
Got it. And there's a classification for CHF severity?
Yes, the New York Heart Association, or NYHA,
Yeah.
classification goes from Class I asymptomatic to class 4, symptomatic even at rest.
And the risk climbs with class.
Dramatically. A class I patient might have only a 3% risk of surgical decompensation, but a class 4 patient faces a huge 25% risk. That's a massive difference.
Yeah, that's significant. What causes CHF?
Many things. Prior heart attacks, valvular heart disease, long-standing hypertension are common culprits.
And how does it present?
If the left side of the heart is failing, you often see pulmonary symptoms, exertional dyspnea, crackles in the lungs on exam. Right-sided failure often shows up as systemic fluid backup, elevated jugular venous pressure in the neck, peripheral edema, swollen ankles.
Diagnosis.
Best tool is usually a transthoracic echocardiogram, an ultrasound of the heart.
In treatment.
Aims to reduce afterload, reduce preload, and sometimes increase contractility. Often involves a cocktail of meds, AC inhibitors, diuretics, beta blockers, sometimes digoxin.
So perioperatively, for CHF patients, what's the focus?
Maintaining their regular medications is key, and being incredibly careful with fluid and electrolyte balance. Potassium levels need close monitoring, and fluid replacement must be very judicious, often guided by more invasive monitoring like a central line.
Makes sense. What about valvular heart disease?
Another area we assess carefully. These abnormalities, often picked up through history and the physical exam listening for murmurs, can profoundly affect cardiovascular stability during surgery.
Like aortic stenosis.
Exactly. Aortic stenosis, AS, where the aortic valve narrows. Whether it's congenital or acquired, the classic symptoms are syncope, fainting, angina, and exertional dyspnea.
And if it's severe?
Critical AS, defined by a very small valve area, less than 0.75 centimeters Rs, or a high-pressure gradient across the valve, is an independent risk factor for morbidity and mortality.
Why is it so risky?
Patients with significant AS simply cannot tolerate increases in heart rate or sudden drops in peripheral resistance, which anesthesia can cause. It makes managing them extremely challenging.
Okay. And there are other valve issues too.
Oh yes, aortic regurgitation, AR,
Yeah.
mitral stenosis, MS, mitral regurgitation, MR, each has its own distinct presentation and specific management considerations. For instance, in significant AR, you often need to avoid beta blockers because slowing the heart gives it more time to leak backward, worsening the regurgitation.
Got it. Now, what if the valve has already been replaced? Prosthetic valve replacement.
Crucial point. Mechanical valves, the metal and carbon ones, always require lifelong anticoagulation, usually with warfarin, to prevent clots forming on the valve.
Always.
Biologic valves, made from animal tissue, generally don't require long-term anticoagulation after about 3 months, unless there are other risk factors like atrial fibrillation.
But they still carry risks.
Yes, patients with any prosthetic valve are susceptible to serious issues like endocarditis, infection of the valve, valve failure over time, or thromboembolic clots breaking off and traveling elsewhere.
So managing the anticoagulation for surgery? That sounds tricky.
It's a very delicate balance. If bleeding is likely during the surgery, the warfarin is often discontinued beforehand.
But stopping warfarin increases clot risk, right? Stroke risk.
Exactly. It's a high-stakes balancing act. So often doctors use what's called bridging therapy.
Bridging?
Yeah. Stopping the long-acting warfarin a few days before and using a shorter-acting anticoagulant like low molecular weight heparin LMWH injections or sometimes unfractionated heparin UFH infusion closer to the time of surgery.
To minimize the time off anticoagulation.
Precisely. For warfarin, the therapeutic INR, that measure of clotting time, is usually targeted between 2.5 and 3.5 for mechanical valves. UFH needs to be stopped about 6 hours before surgery, while LMWH is usually held the night before or morning of.
And infection risk. Endocarditis.
Big concern. Antibiotic prophylaxis is standard requirement for patients with prosthetic heart valves or a history of previous endocarditis or certain congenital heart conditions.
What antibiotics?
The go-to is typically amoxicillin 2 grams orally or ampicillin 2 grams IV or IM given about an hour before the procedure. Clindamycin is a common alternative for those with penicillin allergies.
Okay. Moving on to heart rhythms.
Arrhythmia.
They're abnormal heart rhythms, whether they're already diagnosed or occult, meaning hidden or intermittent. Anesthesia and the stress of surgery can often unmask them.
How do you evaluate them?
Typically starts with a standard 12-lead ECG. If the arrhythmias are intermittent, a 24-hour continuous heart monitor, a Holter monitor, might be needed.
What are some common types? Supraventricular arrhythmias, originating above the ventricles, like SVT, supraventricular tachycardia, where heart rates can exceed 150 BPM, are usually benign hemodynamically but can reduce cardiac output if sustained.
Okay.
Atrial flutter, often recognized by its sawtooth pattern on ECG with an atrial rate around 300 BPM, actually carries a higher surgical mortality risk.
And atrial fibrillation, AFib.
AFib. Incredibly common, especially in older adults. It results in that classic irregular pulse. It reduces cardiac output because the atria aren't contracting effectively. And crucially, it predisposes patients to forming thrombi, blood clots, in the atria, which can embolize and cause strokes.
So AFib patients often need anticoagulation.
Yes, AFib usually requires long-term warfarin or one of the newer anticoagulants to prevent these embolic events.
What about arrhythmias from the ventricles?
Ventricular arrhythmias are generally more concerning. Isolated premature ventricular contractions, PVCs, are common and often harmless. But 3 or more consecutive PVCs are considered ventricular tachycardia, VT, which is a much more serious, potentially life-threatening arrhythmia.
So VT is a red flag for surgery.
Absolutely. Elective surgery should typically be deferred in patients with significant ventricular dysrhythmias like VT until they are evaluated and stabilized.
And heart blocks, problems with the heart's wiring.
Exactly. Conduction abnormalities. Yeah. First-degree heart block, just a slight delay, is usually asymptomatic and doesn't pose a major surgical risk.
But higher degrees.
Second-degree Mobitz and third-degree heart block, complete heart block, are much more serious. They often indicate significant underlying conduction system disease and frequently require external or internal pacing support during surgery, and long-term pacemaker implantation is often necessary before elective procedures.
Okay. Now, hypertension, HTN, super common, defined as systolic over 140 or diastolic over 90 on 2 occasions.
Extremely common, and often a reason given to postpone elective surgery.
So what is it a reason to postpone? Is there a specific number?
That's the critical question.
Yeah.
It's less about a single number and more about the context and whether there's evidence of acute end organ damage.
Okay.
We distinguish between hypertensive urgency, where the blood pressure is very high, but no acute organ damage yet, requiring referral within 24 hours, and a hypertensive emergency.
Emergency meaning?
Elevated BP with signs of acute end organ damage like stroke symptoms, chest pain, kidney failure. That requires immediate ER transport.
And surgery's off the table for both.
For elective surgery, yes, absolutely postponed for both urgency and emergency until controlled. Major risk factors like smoking, diabetes, and age over 60 just compound the risk associated with hypertension.
What about patients with known treated hypertension? Do they keep taking their meds?
Generally, yes. Patients with a history of HTN should typically continue their usual medication perioperatively to maintain control.
But sometimes doses are adjusted.
Yes, some doses might be reduced slightly if the planned anesthesia is likely to cause hypotension. Beta blockers, calcium channel blockers, and clonidine are usually continued right up to surgery.
Which ones might be held?
Diuretics are often held the morning of surgery to prevent dehydration. There's also debate, but ACE inhibitors and angiotensin receptor blockers, ARBs, may be held, as they can contribute to refractory hypotension under anesthesia, though practice varies.
Okay. And you want to avoid diagnosing it after surgery?
Ideally, yes. You don't want the first diagnosis of HTN to be post-operatively, because factors like pain, anxiety, fluid shifts can all artificially elevate blood pressure.
Makes sense. How is a hypertensive emergency treated?
Usually with powerful, short-acting intravenous drugs like labetalol or esmolol in a monitored setting.
And long-term management?
For chronic management of stage I and II hypertension, lifestyle changes are key. Weight loss, exercise, reduced dietary sodium, often combined with a stepwise approach to medications, commonly starting with diuretics, beta blockers, ACE inhibitors, or ARBs.
Okay. Last cardiac topic, AICDs and pacemakers. Automatic implantable cardioverter defibrillators. Seeing more of these.
Definitely. A growing number of patients undergoing surgery have these devices.
And they need special handling.
Absolutely. The decision to reset, reprogram, or temporarily turn them off before surgery is always made in close consultation with the patient's cardiologist and the anesthesiologist.
Why turn them off?
Defibrillators, AICDs, should often be temporarily turned off or at least have the defibrillation function disabled to prevent accidental discharge triggered by electrical interference from surgical equipment, like electrocautery, or worse, damage to the device itself.
Electrocautery is a problem then?
Yes, monopolar electrocautery should be avoided if possible, or used very cautiously, in all patients with an AICD or pacemaker. The electrical current can potentially damage the device, inhibit pacing, or cause inappropriate shocks.
What precautions are needed if it is used?
The grounding pad should be placed far from the device generator, Use should be intermittent and with the lowest effective energy setting, and the device must be interrogated and assessed immediately post-procedure to ensure it's functioning correctly.
And for AICD patients?
External pacing and defibrillation equipment must be readily available in the operating room throughout the surgery, just in case. 3. Deep dive. Respiratory disease.
All right, moving from the heart to the lungs. Respiratory disease presents unique challenges, especially in oral and maxillofacial surgery because of the shared airway, right?
Absolutely. Potential for upper airway obstruction is a major consideration.
And you mentioned functional status for the heart. It's important for lungs, too.
Definitely. Here's where it gets really interesting. How much a patient can do in their daily life, their functional status, often provides significant insight into how severe their underlying lung disease truly is, sometimes more than just the PFT numbers.
Okay. And smoking history.
Critical. Absolutely critical. Post-operative respiratory complications, pneumonia, atelectasis, bronchospasm are much more common in smokers.
Is there a benefit to quitting before surgery?
Huge benefit. The risk of these complications declines by roughly 50% after just 8 weeks of cessation.
8 weeks? That's significant.
Even short-term cessation helps. The carbon monoxide from cigarette smoke elevates carboxyhemoglobin levels, which can lead to falsely high pulse oximetry readings and also increases the risk of cardiac complications. But that specific carboxyhemoglobin effect can be eliminated with just 24 hours of smoking cessation.
Wow. Okay. What about testing?
Preoperative pulmonary testing can range from a simple chest X-ray to basic office peak flow meters up to the gold standard. Pulmonary function testing, or PFTs.
PFTs measure lung volumes.
Exactly. Lung volumes and flow rates like FEV1, the forced expiratory volume in 1 second, and the FEV1-FVC ratio. These give objective measures of airflow obstruction or restriction. PFTs are often accompanied by an arterial blood gas, an ABG, to check oxygen and CO2 levels directly.
And the underlying problem in most lung diseases is?
Ultimately, it's usually hypoxemia and not enough oxygen getting into the bloodstream.
Why does that happen?
Several reasons. Hypoventilation, not breathing enough, diffusion impairment, oxygen can't cross into the blood easily, ventilation perfusion mismatching, air isn't going where the blood is, and shunting, blood bypassing the lungs entirely.
Okay. And management if someone gets hypoxic?
Always involves oxygen administration. We have various methods, each increasing the fractional concentration of inspired oxygen, O2. A simple nasal cannula delivers maybe 4% extra oxygen per liter flow, maxing at around 40% IO2. Masks can deliver more. And intubation with mechanical ventilation allows for up to 100% IO2 if needed.
Let's talk specific conditions. Asthma.
Defined by bronchial hyperresponsiveness and reversible bronchoconstriction. Basically, the airways twitch and narrow easily.
Leading to?
Reduced minute ventilation, airflow obstruction, and ultimately hypoxemia. Patients typically experience episodic dyspnea, wheezing, chest tightness.
And surgery can trigger it.
Yes. Critically, perioperative exacerbations can be triggered by things like pain, stress, anesthetic agents, intubation, or even aspiration.
How do you assess asthma risk?
The frequency, severity, and response to therapy of recent asthma attacks are key predictors. We ask about ER visits, hospitalizations, history of intubation, current medications.
So someone with severe frequent asthma.
Patients with significant asthma say frequent ER visits, prior intubation, needing multiple daily medications are likely ASA Class 3. They may not be good candidates for office-based sedation or general anesthesia due to the risk of severe bronchospasm.
How is asthma confirmed?
Diagnosis is supported by PFTs showing reduced FEV1, which then improves significantly, usually by more than 10–12% after inhaling a bronchodilator like albuterol.
And when should surgery be postponed?
Elective surgery should definitely be postponed if an asthma patient is actively wheezing or if their peak flow rate is less than 80% of their personal best or predicted baseline. They need to be optimized first.
Management involves continuing their meds.
Absolutely. Maintaining their preoperative medications is crucial. These are often categorized by asthma severity, intermittent, mild persistent, moderate persistent, severe persistent.
What kinds of meds?
Commonly include short-acting beta agonists, SABAs, like albuterol for rescue, inhaled corticosteroids, ICS for maintenance, long-acting beta agonists, LAVs, sometimes leukotriene modifiers or other agents.
And if an exacerbation happens during or after surgery?
It's treated aggressively with inhaled SABAs, often combined with anticholinergics like ipratropium, and frequently requires a short course of oral or intravenous corticosteroids to calm the airway inflammation.
Okay. What about chronic obstructive pulmonary disease, COPD?
COPD encompasses two main conditions,
Yep.
emphysema and chronic bronchitis.
The pink puffers and blue bloaters.
Exactly. Patients with predominantly emphysema often have dilated airways and destruction of the alveoli, leading to air trapping. They might maintain oxygenation better initially, hence being puffer.
And chronic bronchitis.
That's characterized by increased airway secretions, chronic cough, and mucus production. These patients often have more pronounced hypoxemia and cyanosis, hence blue bloater, but really, most patients have features of both.
And the result is similar.
Both ultimately result in airflow limitation, carbon dioxide retention, and hypoxemia.
Symptoms.
Chronic cough, often productive sputum, and progressive shortness of breath, especially with exertion.
Diagnosis.
Relies on history, especially smoking history, PFT showing reduced FEV1 and a characteristically low FEV1-FVC ratio that doesn't improve much with bronchodilators. ABGs often showing increased PCO2 and decreased PO2, and chest X-ray findings like hyperinflation or flattened diaphragms.
Smoking cessation is key here, too.
Absolutely. Ideally, cessation should occur more than 8 weeks before surgery to get the most benefit in reducing complications.
And surgery during a flare-up.
Elective surgery is definitely contraindicated during an acute COPD exacerbation, characterized by increased cough, sputum, and shortness of breath. Need to treat the exacerbation first.
Perioperative management for stable COPD.
Aims to maintain their preoperative medication regimen, often similar agents to asthma, like bronchodilators and sometimes inhaled steroids.
Any specific anesthetic concerns?
Nitrous oxide is often best avoided, especially in emphysema, because it can accumulate in existing lung bullae and potentially rupture them. Also, careful attention to ventilator settings is needed, keeping plateau pressures moderate to prevent barotrauma.
Post-op exacerbations are common.
Unfortunately, yes, they're treated similarly to acute exacerbations. Supplemental oxygen, SABAs, anticholinergics, and often systemic corticosteroids.
What about the concern of giving oxygen knocking out their respiratory drive?
That's the classic theoretical concern that some severe COPD patients rely on a low oxygen level, hypoxic drive, to stimulate breathing. However, in reality, the risk of harm from untreated hypoxemia far outweighs the small risk of reducing respiratory drive. Hypoxemic patients, regardless of COPD status, should always be treated aggressively with oxygen to maintain adequate saturation.
Good clarification. Next, pneumonia can occur after surgery.
Yes, nosocomial pneumonia, particularly ventilator-associated pneumonia, VAP, can be a serious postoperative complication.
What causes it?
Common causative organisms include bacteria like Streptococcus pneumonia, Staphylococcus aureus, and gram-negative rods like Pseudomonas.
Signs.
Dyspnea, fever, productive cough, sometimes chest pain, and decreased breath sounds or crackles over the affected area.
Diagnosis.
Relies on the clinical picture, imaging, chest X-ray or CT showing a new infiltrate, and ideally sputum or blood cultures to identify the organism and guide antibiotic choice. Treatment involves prompt parenteral antibiotics.
Okay. Pulmonary embolus, PE, blood clot in the lungs. Where do they come from?
Over 95% of PEs originate from deep vein thrombosis, DVTs, in the legs or pelvis.
Risk factors.
Many. Smoking, oral contraceptives, underlying malignancy, recent surgery, especially orthopedic or major abdominal, prolonged immobilization, inherited clotting disorders.
So prevention is key.
Absolutely crucial, especially in higher-risk surgical patients. This includes mechanical methods like sequential compression devices, SCDs on the calves, thromboembolic deterrent stockings.
And medication.
Yes, pharmacological prophylaxis with perioperative unfractionated heparin, UFH, or low molecular weight heparin, LMWH, is often used.
And getting patients moving.
Paramount. Early ambulation is probably one of the most effective preventative measures.
Signs and symptoms if a PE does happen.
Can be varied and nonspecific, but classic signs include sudden onset of pleuritic chest pain, worse with breathing, shortness of breath, tachypnea, fast breathing, tachycardia, fast heart rate, sometimes signs of DVT like a swollen, tender leg.
Workup.
May include an ADG, often shows respiratory alkalosis and hypoxemia, a D-dimer blood test. A negative D-dimer makes PEDDT very unlikely, but a positive one is nonspecific. Imaging like a CT pulmonary angiogram, CTPA, the current standard, a VQ scan, or a duplex ultrasound of the leg veins to look for DVT.
Treatment.
Involves immediate anticoagulation, usually starting with heparin, UFH or LMWH, followed by transition to long-term oral anticoagulation, often warfarin, for at least 3 to 6 months.
What about massive PE?
Massive PE, causing hemodynamic instability, may require more aggressive treatment, like chemical thrombolysis, clot-busting drugs, or even surgical thrombectomy.
Okay. Atelectasis. common post-op issue.
Very common.
Yeah.
It's basically a segmental collapse of lung alveoli, the tiny air sacs.
Why does it happen?
Often due to shallow breathing after surgery, pain, sedation, retained secretions blocking small airways.
What does it cause?
Leads to decreased lung compliance, stiffer lungs, ventilation-perfusion mismatch, and retained secretions, increasing pneumonia risk. Signs include decreased breath sounds over the affected area and often a low-grade fever in the first day or two post-op.
Treatment.
Relatively straightforward and focused on prevention and re-expansion. Incentive spirometry, encouraging deep breaths, coughing and deep breathing exercises, chest physiotherapy sometimes, and again, early ambulation.
Good. Pulmonary edema, fluid in the lungs, cardiac causes.
Can definitely be cardiac from heart failure, but it can also be non-cardiac.
Like
A notable one is negative pressure pulmonary edema, NPPE. It can happen after extubation, especially in young, strong, often male patients. If they bite down on the tube or have laryngospasm while trying to take a deep breath against an obstructed airway, they generate intensely negative pressure in their chest.
Pulling fluid into the lungs.
Exactly. Pulls fluid from the capillaries into the alveoli. Risk factors include obesity and obstructive sleep apnea.
Signs.
Sudden onset of respiratory distress after extubation, pink frothy sputum sometimes, increased work of breathing, bilateral crackles on exam.
Treatment for NPPE.
Supportive. Supplemental oxygen, maintaining airway patency, sometimes positive pressure ventilation, CPAP or BiPAP, and occasionally may require reintubation and mechanical ventilation with PEEP, positive end expiratory pressure, to help push the fluid out and keep alveoli open. Usually resolves relatively quickly with support.
Okay, final respiratory topic, but a huge one. The airway. Assessing it is mandatory.
Absolutely mandatory. Complications related to establishing and maintaining an airway are a significant source of morbidity and mortality in anesthesia and surgery.
How does the assessment begin?
Starts with patient history. Crucially, ask about any prior difficult airways, problems with anesthesia, snoring, sleep apnea.
Then the physical exam.
Yes, looking for predictors of difficulty. Weight, BMI, obesity often means more soft tissue, reduced neck mobility, potentially reduced functional residual capacity, decreased cervical range of motion, can they tilt their head back, decreased maximum incisal opening, how wide can they open their mouth, a retrognathic mandible, small or recessed jaw, large tongue, short neck.
Any specific conditions?
Certain congenital conditions like Pierre-Robin sequence or Down syndrome are known to portend difficult airways. Previous neck surgery or radiation too.
And the Malampati classification, we hear about that.
Yes, the Malampati classification is a common bedside tool used to predict the ease of direct laryngoscopy and intubation.
How does it work?
It involves having the patient sit up, open their mouth wide, and stick out their tongue without saying, ah. You look at what structures you can see in the back of their throat.
Class I is easy.
You can visualize the entire soft palate. Uvula, fauces, and tonsillar pillars generally predicts an easy intubation. As you go up to class 4, where you can only see the hard palate.
Harder intubation.
The less you see, the higher the likelihood of a difficult intubation. Class 3 and 4 are associated with increased difficulty.
So if you anticipate difficulty,
You need backup plans and equipment immediately available. Supplemental measures like a good jaw lift, oral or nasal airways, a positive pressure bag valve mask system. Surgeons and anesthesiologists should be proficient in alternative airway techniques like laryngeal mask airway, LMA, insertion, endotracheal tube insertion using different blades or video laryngoscopy, and in emergency situations, cricothyroidotomy.
and maybe do the case in a hospital?
Patients identified with potentially difficult airways are often much better candidates for hospital-based procedures where more advanced techniques, like awake fiber optic intubation, and specialized personnel are readily available rather than an office setting. Safety first. 4. Deep dive. Renal disease.
Okay, shifting gears to the kidneys. Renal disease, kidney failure, also directly correlates with surgical risk.
Absolutely. Significant impact on morbidity and mortality. And what's fascinating, or perhaps concerning, is how seemingly minor changes in standard lab values can actually indicate significant underlying kidney damage.
How so?
Well, common conditions like long-standing hypertension and diabetes are notorious for gradually diminishing renal function over years. The normal glomerular filtration rate, GFR, is around 120 millilem.
Okay.
But a noticeable rise in serum creatinine, or blood urea nitrogen, PUN, might not even be seen until the GFR decreases to about 30 millilem. That means you could have lost 75% of your kidney function before these basic tests become clearly abnormal.
Wow, that's a lot of lost function.
It is. As renal disease progresses, urine production naturally declines, leading eventually to oliguria, low urine output, or anuria, no urine output.
And other problems follow.
Yes, a whole cascade. Chronic kidney disease leads to anemia. Kidneys make erythropoietin, hypoalbuminemia, critical electrolyte abnormalities, problems managing sodium, potassium, calcium, magnesium, phosphorus, and impaired acid-base homeostasis, often leading to metabolic acidosis.
So basic assessment.
Always includes monitoring urine output, serum creatinine, BUN, serum electrolytes, bicarbonate levels, and hematocrit for anemia.
Creatinine and BUN give an idea of function.
They provide indirect evidence. The GFR itself can be estimated using formulas like the Cockcroft-Gault or the MDRD equation, which factor in creatinine, age, sex, race, and sometimes weight.
Okay. What if kidney function acutely worsens around surgery?
Perioperative acute kidney injury, AKI, can be broadly classified by its cause. Pre-renal, meaning issues before the kidney, usually related to reduced blood flow, like hypovolemia, shock, heart failure.
Okay, flow problems.
Renal or intrinsic, meaning actual damage to the kidney tissue itself, like from glomerulonephritis, acute tubular necrosis, often due to toxins or ischemia.
Damage within the kidney.
And postrenal, meaning an obstruction after the kidney, blocking urine outflow, like from an enlarged prostate, kidney stones, or a blocked catheter.
Blockage downstream. Is there a way to tell these apart?
A helpful test is the fractional excretion of sodium, the FeNA, calculated from urine and serum sodium and creatinine levels.
How does that help?
In pre-renal states, the kidney is trying hard to conserve sodium and water, so the FeNA is typically low, less than 1%. In intrinsic renal damage, the tubules can't reabsorb sodium properly, so FeNA is usually high, above 2%. Postrenal obstruction often has a very high FeNA, above 4%. It helps guide treatment.
Smart. So, perioperative management for patients with kidney issues.
Big focus on fluid status. Avoiding both dehydration and excessive intravenous fluid is key, as is avoiding excess potassium, since the kidneys can't excrete it properly.
Anemia management.
Acutely, managed with packed red blood cell transfusions if severe or symptomatic. Chronically, often managed with erythropoietin-stimulating agents, ESAs, and iron supplementation.
And potassium. Hyperkalemia.
Hyperkalemia, a high potassium level, usually defined as above 5.5 millieqlol, is a critical concern. It can cause severe, potentially fatal cardiac arrhythmias.
How is it treated urgently?
Requires urgent treatment, intravenous calcium gluconate to stabilize the heart muscle membranes, agents to shift potassium into cells like insulin with dextrose, or agents to remove potassium from the body like kioxalate resin or loop diuretics. Severe hyperkalemia may necessitate emergency hemodialysis.
What about medications in general?
Another critical point. Many medications need careful consideration. Nephrotoxic drugs like NSAIDs and certain antibiotics, for example, aminoglycosides, vancomycin, if levels aren't monitored, may need to be discontinued or used with extreme caution.
And dosing adjustments.
Many drugs that are primarily excreted by the kidneys need to be renally dosed. Often this means reducing the frequency of administration, for example, giving it every 12 or 24 hours instead of every 8, rather than just reducing the dose amount to prevent accumulation.
And for patients already on dialysis, end-stage renal disease.
For patients with ESRD on hemodialysis, elective surgery is ideally scheduled for the day after their dialysis session.
Why then?
That's when their fluid volume and electrolyte balance are typically at their most optimal, minimizing perioperative risks related to fluid overload or electrolyte disturbances. 5. Deep dive. Liver disease.
Okay, from kidneys to the liver. Liver disease can also significantly impact the perioperative period, right? And you mentioned it can be subtle.
Very much so. What's fascinating, or again, concerning, is how subtle the initial signs can be. A patient might look and feel relatively fine, but their liver could be significantly compromised.
How do you pick it up then? History.
A careful history is definitely key. We look for risk factors like significant alcohol use, intravenous drug use, history of viral hepatitis, prior blood transfusions, especially before widespread screening.
What about signs on exam?
Sometimes outward signs are absent initially, but they can include non-specific things like fatigue or more specific signs like jaundice, yellowing of skinnies, pulmar erythema, red palms, spider angiomas, ascites, fluid in the abdomen causing increased girth, or caput medusae, dilated veins around the navel.
And cirrhosis.
Cirrhosis, the end stage of chronic liver disease where normal tissues are replaced by scar tissue, often leads to portal hypertension, increased pressure in the veins draining the gut. This in turn carries a significantly increased risk of bleeding, particularly from esophageal varices.
When is surgery contraindicated?
As a general rule, elective surgery is often contraindicated in patients with acute hepatitis, active inflammation, or severe decompensated chronic liver disease. For example, active variceal bleeding, severe ascites, hepatic encephalopathy.
What are the main perioperative concerns with liver disease?
Several big ones. The liver is crucial for drug metabolism, so liver disease can profoundly impair how a patient processes many medications, especially anesthetics and analgesics.
Okay, drug handling. What else?
It can affect respiratory function due to conditions like hepatopulmonary syndrome or hepatic hydrothorax, and critically, it predisposes patients to excessive bleeding.
Why the bleeding risk?
Because the liver synthesizes most of the essential clotting factors, particularly the vitamin K-dependent factors, 2, 7, 9X. Impaired synthesis leads to a prolonged prothrombin time, PT and INR. Thrombocytopenia, low platelets, due to hypersplenism is also common.
How do you stratify risk for liver patients?
Risk stratification has evolved. The older Child-Pugh classification was used for years. Now, the model for end-stage liver disease, or MELD-E system, is more widely used, especially for predicting short-term mortality.
MELD-E score. What goes into that?
It's calculated from 3 simple lab values: serum creatinine, total bilirubin, and the INR.
And how does this score guide surgical decisions?
It's quite predictive. Generally, patients with a MELD score less than 10 are considered relatively low risk and can often undergo elective surgery safely. Between 10 and 15, surgery can be considered, but with extreme caution and optimization. A MELD score greater than 15 is associated with very high perioperative mortality, and elective surgery should generally be avoided.
What tests assess liver function?
Standard liver function tests, LFTs, include liver enzymes like AST and ALT, indicators of liver cell injury, alkaline phosphatase and GGT, indicators of biliary issues, bilirubin, measures bile processing, albumin, measures synthetic function, and the PT-INR, measures clotting factor synthesis.
So perioperative goals for these patients.
Key goals include correcting any coagulopathy. An elevated PT-INR might be treated with intravenous vitamin K or, if urgent, fresh frozen plasma, FFP. Managing ascites often involves diuretics like spironolactone and furosemide, and sometimes large volume paracentesis, draining the fluid.
Fluid management.
Strict limitation of intravenous fluid and especially sodium intake is crucial to avoid worsening ascites and edema. Electrolyte abnormalities like hypokalemia or hyponatremia are common and must be cautiously monitored and corrected.
Any other considerations?
Antibiotic prophylaxis may also be considered in some cases, particularly if ascites is present, to reduce the risk of spontaneous bacterial peritonitis, SBP. 6. Deep dive. Blood disorders.
All right, let's talk blood disorders. These can clearly impact surgical safety in major ways. It's not just about bleeding.
Not at all. It's about oxygen carrying capacity, clotting, fighting infection, the whole system.
So what are some of the most critical blood issues we need to consider before surgery?
Well, let's start with anemia. Very common. It's an absolute or relative reduction in hemoglobin or hematocrit concentration.
Meaning the blood can't carry enough oxygen.
Exactly, leading to tissue hypoxemia. If the anemia is significant or symptomatic, causing fatigue, shortness of breath, chest pain, elective surgery might need to be delayed until the cause is identified and treated.
How is it diagnosed?
Starts with a complete blood count, the CBC. That checks the red blood cell number, hemoglobin level, hematocrit percentage, and importantly, the RBC indices like mean corpuscular volume, MCV, which tells us the average size of the red cells.
MCV helps narrow down the cause.
Yes. And the reticulocyte count, which measures the rate of new red blood cell production by the bone marrow, helps distinguish between problems of decreased production versus increased destruction or loss.
So different types based on cell size.
Right. Microcytic anemia, low MCV, small cells. The most common cause by far is iron deficiency. But it can also be due to thalassemia, an inherited hemoglobin disorder, or anemia of chronic disease, sometimes even lead poisoning.
And large cells.
Macrocytic anemia, high MCV, large cells, is often due to vitamin B12 or folic acid deficiency. These are needed for DNA synthesis during red cell production. Liver disease and alcoholism can also cause macrocytosis.
What about specific inherited anemias like sickle cell?
Sickle cell anemia is particularly important, especially in individuals of African, Mediterranean, or Middle Eastern descent. In its homozygous form, sickle cell disease, the abnormal hemoglobin causes red blood cells to deform into a rigid sickle shape under stress, like low oxygen or dehydration.
Leading to
Painful vaso-occlusive crises, where these sickled cells block small blood vessels. Over time, this causes chronic pain, organ damage, spleen, kidneys, lungs, brain, cardiomyopathy.
So major implications for surgery.
Huge. Perioperative management focuses intensely on preventing sickling triggers. Meticulous hydration, ensuring excellent oxygenation, maintaining body temperature, and aggressive pain control. Sometimes preoperative blood transfusions are needed to reduce the percentage of sickle hemoglobin. Hydroxyurea is a medication used for long-term management.
Okay. What about disorders of cell overproduction?
Right, the myeloproliferative diseases. These are a group of disorders characterized by excessive proliferation of myeloid cells in the bone marrow. They have the potential to transform into acute leukemias over time. Polycythemia vera involves an elevated red blood cell count, high hematocrit, leading to hyperviscosity, thick blood, risk of thrombosis or bleeding. Essential thrombocytosis involves a very high platelet count, also increasing risk of clotting or sometimes paradoxical bleeding.
And cancers like leukemia, lymphoma, myeloma.
Yes, leukemia, cancer of white blood cells, lymphoma, cancer of lymph tissue, and multiple myeloma, cancer of plasma cells, also present significant perioperative challenges. Patients often have anemia, thrombocytopenia, low platelets, and are immunocompromised, increasing infection risk.
Multiple myeloma and jaw issues?
Yes, importantly, many patients with multiple myeloma are treated with bisphosphonates to strengthen bones, which carries the risk of medication-related osteonecrosis of the jaws, MRONJ, formerly Baron J, a serious complication following dental procedures or spontaneously.
Okay. Shifting to low platelets, thrombocytopenia.
Defined as a platelet count below the normal range, but clinically significant bleeding risk usually increases when the count drops below 50,000 Salcido. Spontaneous bleeding can occur below 10,000, 20,000.
What causes it?
Many causes. Decreased production, bone marrow problems, B12 folate deficiency, increased destruction, autoimmune disorders like ITP, immune thrombocytopenic purpura, drug-induced infections, or sequestration, platelets trapped in an enlarged spleen. Also, severe conditions like TTP, thrombotic thrombocytopenic purpura, HUS, hemolytic uremic syndrome, and DIC, disseminated intravascular coagulation.
Management, platelet transfusion.
Platelet transfusions may be needed if the count is critically low or if there's active bleeding, especially before surgery. Treating the underlying cause is key. Patients with active DIC are generally not surgical candidates due to the simultaneous uncontrolled bleeding and clotting.
Which brings us to coagulopathy and general problems with clotting.
Right, abnormalities in either the platelets or the protein clotting factors in the coagulation cascade. A personal or family history of easy bruising or prolonged bleeding after minor cuts or dental work is a crucial red flag.
Assessment
Includes the CBC for platelet count, platelet function tests if indicated, and coagulation tests like prothrombin time, PT, international normalized ratio, INR, which assesses the extrinsic pathway, and partial thromboplastin time, PTT, which assesses the intrinsic pathway.
Platelet function can be abnormal even if the count is okay.
Yes. Platelet function defects can be inherited, like von Willebrand's disease, the most common inherited bleeding disorder, affects platelet adhesion. Or rarer disorders like Glanzmann's thrombasthenia.
Or acquired.
More commonly, acquired platelet dysfunction happens from medications like aspirin, NSAIs, clopidogrel, Plavix, or due to medical conditions like uremia and end-stage renal disease.
What's the target platelet count for surgery?
The general aim for most surgical patients is a platelet count above 50,000 cells, though some might aim for 80,000 or 100,000 for a major or neurosurgery.
What about inherited clotting factor deficiencies, hemophilia?
Hemophilia A, factor VIII deficiency, and hemophilia B, factor IXX deficiency, Christmas disease, are X-linked recessive disorders, mainly affecting males. They cause bleeding, especially into joints and muscles. Severity depends on the level of factor activity.
Management for surgery.
Requires close collaboration with a hematologist. Preoperative replacement therapy with the specific deficient clotting factor concentrate is necessary, with the dose and frequency tailored to the severity of the deficiency and the type of surgery planned to maintain adequate factor levels throughout the perioperative period.
Okay. And back to warfarin therapy. We discussed bridging. What if surgery is minor?
For very minor procedures with low bleeding risk, like simple dental extractions, warfarin may sometimes be maintained, especially if the therapeutic INR is not too high, for V 3.0 or 3.5, combined with meticulous local hemostatic measures, pressure, sutures, hemostatic agents. But this is a case-by-case decision.
And for major surgery, bridging is the standard.
For major surgery, where significant bleeding is anticipated, stopping warfarin 4 to 5 days prior and bridging with LMWH or UFH is generally necessary to balance bleeding and clotting risks.
And reversal.
In cases of active bleeding or emergent surgery in a patient on warfarin, it can be rapidly reversed with intravenous vitamin K, takes hours, or more immediately with prothrombin complex concentrates, PCCs, or fresh frozen plasma, FFP.
Lastly, the opposite problem, hypercoagulable diseases. Increased clotting risk.
Yes, conditions that predispose patients to thrombosis, DVT, PE, arterial clots. These can be inherited, like factor V Leiden mutation, prothrombin gene mutation, deficiencies of protein CS or antithrombin, or acquired, like malignancy, pregnancy, antiphospholipid syndrome, prolonged immobility.
Management focuses on prevention.
Absolutely. For patients with known hypercoagulable states or at high risk, prevention of DVT and PE is paramount. Early ambulation, SCDs, and often prophylactic or even therapeutic doses of heparin or LMWH perioperatively. 7. Deep dive. Endocrinology.
Okay, let's unpack the endocrine system. Hormones play a huge role, right? And diseases like diabetes and thyroid disorders can drastically change how a body responds to surgical stress.
Absolutely. They are major players in preoperative assessment and management. Let's start with the big one. Diabetes mellitus, DM.
Characterized by high blood sugar?
Right. Elevated blood glucose due to either insufficient insulin production, type 1, or insulin resistance, type 2, much more common. Over time, this hyperglycemia can lead to devastating microvascular and macrovascular complications.
Affecting
Cardiovascular system, CAD, MI, cerebrovascular system, stroke, kidneys, nephropathy, renal failure, nervous system, neuropathy, eyes, retinopathy, blindness.
initial symptoms?
Maybe the classic polys, polyphagia, excessive hunger, polydipsia, excessive thirst, and polyuria, excessive urination. Also fatigue, blurred vision, slow wound healing.
Diagnosis criteria?
Typically based on plasma glucose levels. A random blood glucose 200 milligdl with symptoms, or a fasting blood glucose 126 milligdl on 2 occasions, or a 2-hour glucose 200 milligdl during an oral glucose tolerance test, OGTT. Hemoglobin A1C 6.5% is also diagnostic.
Okay. Now, for diabetic patients undergoing surgery, especially general anesthesia or IV sedation where they'll be fasting, managing their glucose is critical.
Incredibly critical and complex.
Yeah.
The goal isn't just avoiding low sugar, it's maintaining relatively tight control to minimize complications like poor wound healing and infection.
What's the target range?
The general goal during the perioperative period is to maintain blood glucose roughly between 80 and 180 milligdl, though tighter control, maybe 80-140, is often aimed for, especially in critically ill patients. Avoiding hypoglycemia, 70 milligdl, is paramount.
How is it managed if they're fasting? What about their home meds?
It requires careful adjustment. For patients not treated with insulin, type 2 on oral agents, the oral agents are typically held the morning of surgery. Glucose is monitored and often a sliding scale insulin, SSI regimen, is used, giving doses of short-acting insulin based on finger stick readings.
What if SSI isn't enough?
For patients with poor baseline control, for example, A1C 8 to 9%, or significant hyperglycemia perioperatively, 180 to 200 milligdl, a continuous insulin infusion, CII, might be needed for more precise control.
What about patients already on insulin?
For insulin-treated patients, it depends on the type of insulin and the surgery. Short-acting, mealtime insulin is usually held while fasting. Basal insulin, long-acting like Glargine or Detamir or insulin pump basal rates, is often continued, perhaps at a reduced dose, for example, 50–80% of usual dose, to prevent ketoacidosis. Again, frequent monitoring in SSI or CII are used.
The formula for SSI is often based on?
A common simple formula might be something like units of regular insulin. Blood sugar level target may be 140, sensitivity factor, example 40 or 50. But protocols vary widely.
What are the big diabetic complications to watch for perioperatively?
Poor wound healing and increased risk of surgical site infection are major concerns with hyperglycemia. Hypoglycemia from overtreatment is dangerous. Hyperglycemia itself can cause dehydration, and then the severe metabolic emergencies.
DKA.
Diabetic ketoacidosis, DKA, primarily in type 1 diabetics, is a serious condition with severe hyperglycemia, dehydration, acidosis, and ketosis. Also, hyperosmolar, hyperglycemic state, HHS, mainly in type 2, involves extreme hyperglycemia and dehydration without significant ketoacidosis. Both have high mortality if not treated promptly and aggressively.
Okay, moving to the thyroid. Hypo or hyperthyroidism?
Right. Hypothyroidism, an underactive thyroid, causes a general slowing of metabolism. Symptoms can be insidious, fatigue, weight gain, cold intolerance, constipation, depression, dry skin.
Does it affect surgery?
Mild, stable hypothyroidism is generally not a contraindication to elective surgery, as long as the patient is taking their levothyroxine replacement.
What about severe hypothyroidism?
Severe, untreated hypothyroidism poses risks. The extreme emergent form is myxedema coma, characterized by hypothermia, altered mental status, respiratory failure. This requires immediate intravenous levothyroxine and corticosteroids, and surgery is definitely postponed until stabilized.
And the opposite, hyperthyroidism.
Overactive thyroid.
Often due to Graves' disease, an autoimmune condition. This carries a specific life-threatening perioperative risk called thyroid storm.
Thyroid storm sounds bad.
It is. It's an acute, severe exacerbation of hyperthyroidism, often triggered by stress like surgery or infection, characterized by high fever, tachycardia, cardiac arrhythmias like AFib, heart failure, agitation, delirium, coma, high mortality rate.
Symptoms of hyperthyroidism itself.
Tachycardia, palpitations, anxiety, tremor, weight loss despite increased appetite, heat intolerance, sweating, sometimes eye changes, exophthalmos, and Greaves.
How is it treated and managed for surgery? Treatment for hyperthyroidism might involve antithyroid drugs like methimazole or propylthiouracil, radioactive iodine ablation, or thyroidectomy. Perioperatively, beta blockers like propranolol are crucial to control heart rate and symptoms.
When should surgery happen?
For both hypo and hyperthyroidism, elective surgery should ideally be delayed until the patient is biochemically euthyroid, normal thyroid hormone levels, to minimize risks like thyroid storm or cardiovascular instability.
Got it. Next, the adrenal glands, sitting atop the kidneys.
Right. They produce cortisol, stress hormone, aldosterone, saltwater balance, and adrenaline. Patients can present with excessive adrenal function.
Like Cushing's.
Cushing's syndrome, excess cortisol, causes central obesity, muscle weakness, easy bruising, hypertension, hyperglycemia. Conn syndrome, excess aldosterone, primarily causes hypertension and hypokalemia, low potassium. These conditions mainly impact fluid balance, electrolytes, and glucose control perioperatively.
What about insufficient adrenal function?
This is often more critical for surgery. Adrenal insufficiency, Addison's disease, if it's primary failure of the adrenal gland itself, secondary if due to pituitary issues or chronic steroid use, means the body can't produce enough cortisol, especially under stress.
And surgery is a big stress.
Huge stress. Patients with known adrenal insufficiency or those on chronic high-dose steroids, which suppresses their own adrenal function, are at high risk for an acute adrenal crisis when stressed by surgery or infection.
What does that look like?
Hypotension refractory to fluids and vasopressors.
Shock.
Weakness, nausea, vomiting, fever, confusion can be fatal if not recognized and treated.
Treatment requires extra steroids.
Absolutely. It mandates a significant increase in their perioperative steroid dose, often called a stress dose. For major procedures, intravenous hydrocortisone equivalent to or greater than 150 milligram per day, sometimes cited as 300 milligram cortisol equivalent, is needed, tapered down postoperatively as the stress resolves.
Okay. Lastly, for endocrine, pituitary disease.
The pituitary gland controls many other endocrine glands. One notable condition affecting fluid balance is diabetes insipidus, DI.
Not related to sugar diabetes.
No, completely different. DI is characterized by the inability to concentrate urine, leading to excretion of large volumes of dilute urine, polyuria, and intense thirst, polydipsia.
What causes it?
Can be central DI due to decreased production or release of antidiuretic hormone, ADH, also called vasopressin, from the pituitary gland, or nephrogenic DI, where the kidneys are insensitive to ADH.
Diagnosis?
Often involves a water deprivation test. Central DI typically responds well to treatment with synthetic ADH, like DDAVP, desmopressin.
Perioperative management.
Focuses heavily on meticulous monitoring and management of fluid intake and output and serum sodium levels, because these patients can rapidly become dehydrated and develop hypernatremia, high sodium, if fluid intake doesn't keep up with urine losses. 8. Deep dive. Neurologic disease.
Okay, let's turn to the brain and nervous system. Neurologic conditions can present significant perioperative challenges too, right? Small changes can have big impacts.
Definitely. Close attention is needed. Starting with acute situations like trauma.
Head injury.
Right. Acute neurologic deterioration requires a rapid, systematic approach. We follow the primary survey: airway, breathing, circulation, disability, neurologic status, exposure.
Disability assessment.
The Glasgow Coma Scale, or GCS, is the standard tool used to quickly assess the level of consciousness and severity of brain injury. It scores eye-opening, verbal response, and motor response, ranging from 3, deep coma, to 15, fully awake.
When is intubation needed based on GCS?
A GCS score of 8 or less, GCS less than 8, intubate, typically mandates endotracheal intubation to protect the airway from aspiration and ensure adequate ventilation and oxygenation, as these patients often can't maintain their own airway reflexes.
Okay. What about seizures?
Seizures can occur perioperatively, either in patients with known epilepsy or sometimes as a new onset event in previously healthy individuals.
What can trigger them around surgery?
Causes vary widely. Anesthesia-related drugs themselves can sometimes lower the seizure threshold, or high doses of local anesthetics can cause seizures. A last, local anesthetic systemic toxicity. Meperidine, Demerol, an opioid, as a metabolite, normoperidine, that can promote seizures, especially with renal insufficiency. Electrolyte disturbances can trigger them, and critically, drug and alcohol withdrawal are significant causes of perioperative seizures.
If someone has a new seizure.
New onset seizures always require immediate treatment to stop the seizure, usually with benzodiazepines like lorazepam or diazepam, and a thorough diagnostic workup to find the underlying cause.
And patients with known epilepsy.
Their regular anti-seizure medication should always be maintained throughout the perioperative period, often given IV if they can't take oral meds. Abruptly stopping these medications can trigger status epilepticus, a dangerous prolonged seizure state.
Okay, cerebrovascular accident, CVA stroke, risk during surgery.
Yes. Atherosclerosis, hardening of the arteries, in the carotid arteries supplying the brain or the cerebral vessels themselves, puts patients at risk for both stroke, CVA, and transient ischemic attacks, TIAs, perioperatively. Factors like hypotension or hypertension or emboli can trigger an event.
Can you reduce the risk? Carotid surgery?
If your patient has significant carotid artery stenosis, typically greater than 70% narrowing, they may benefit from a carotid endarterectomy, CEA, or stenting before undergoing other major elective surgery to reduce the risk of perioperative stroke.
And atrial fibrillation.
As we mentioned, patients with atrial fibrillation are at increased risk for embolic stroke due to clots forming in the heart. They should generally continue their anticoagulation, like warfarin, perioperatively, balancing stroke prevention against surgical bleeding risk.
That makes sense. One more, myasthenia gravis, MG. What is that?
MG is an autoimmune disease characterized by antibodies attacking the acetylcholine receptors at the neuromuscular junction. This impairs nerve signal transmission to muscles, causing fluctuating muscle weakness that worsens with activity and improves with rest.
How does it affect surgery?
It's often exacerbated by physiological stress, like surgery or infection, or by certain medications, including some antibiotics, beta blockers, and especially neuromuscular blocking agents used in anesthesia.
What's the big risk?
A myasthenic crisis can occur, leading to severe generalized weakness, particularly affecting respiratory muscles, causing respiratory distress or failure to wean from mechanical ventilation postoperatively. This requires very careful anesthetic management and close collaboration with the patient's neurologist.
Diagnosis.
Supported by clinical findings, fatigable weakness, electromyography, EMG showing decrement with repetitive nerve stimulation, antibody testing, and sometimes the edrophonium tensilon test, where weakness transiently improves after injecting the short-acting anticholinesterase drug. 9. Deep dive. Other conditions.
All right, to wrap up our deep dive, let's touch on a few more conditions. These are maybe less common or span multiple systems, but they all demand a careful, considered approach perioperatively, kind of the wild cards.
Exactly. They can definitely complicate things. One of the most feared, though rare, is malignant hyperthermia, MH.
What is it? Genetic?
Yes, it's a serious, potentially fatal, inherited pharmacogenetic disorder of skeletal muscle. It causes a hypermetabolic state triggered by exposure to certain volatile anesthetic gases like halothane, sevoflurane, desflurane, and the depolarizing muscle relaxant succinylcholine.
What happens?
A massive, uncontrolled release of calcium within muscle cells leads to sustained muscle contraction, rigidity, massive oxygen consumption, heat production, hyperthermia, and rhabdomyolysis, muscle breakdown.
Early signs.
One of the earliest and most specific signs is often an unexpected and rapid rise in end-tidal carbon dioxide, hypercarbia, that doesn't respond to increased ventilation. This is quickly followed by tachycardia, muscle rigidity, especially jaw muscle rigidity, masseter spasm, and then the hallmark late sign, rapidly rising core body temperature.
How is it treated? It's an emergency.
Yeah. A true anesthetic emergency. Treatment must be immediate and aggressive. Stop this triggering agent immediately, call for help, hyperventilate with 100% oxygen, administer dantrolene intravenously, a specific muscle relaxant antidote for MHT, even lots of it, often 20-30 vials ready, actively cool a patient, ice packs, cold IV fluids, treat arrhythmias and electrolyte abnormalities like hyperkalemia from muscle breakdown, and support hemodynamics. Prompt recognition and treatment are key to survival.
Scary. Okay, what about autoimmune diseases generally, like RA, lupus?
A whole multitude of autoimmune diseases, rheumatoid arthritis, RA, systemic lupus erythematosus, SLE, scleroderma, ankylosing spondylitis, etc., present challenges. They often involve chronic inflammation and immune system dysregulation, which can increase perioperative complications.
How so?
Organ systems can be directly targeted by the disease, leading to specific airway, pulmonary, cardiovascular, renal, or hematologic difficulties, depending on the condition. Wound healing may be impaired due to the disease or its treatments, like steroids. And surgical site infections can be more common due to immunosuppression.
Specific examples: rheumatoid arthritis, RA.
RA can involve the cervical spine, causing instability and landoaxial subluxation, which requires extreme care during neck manipulation for intubation. It can also affect the temporomandibular joint, TMJ, limiting mouth opening, and even the small joints of the larynx, potentially narrowing the airway.
And their medications.
Many medications used for autoimmune diseases cause complications themselves. NSAIDs reduce platelet function. Glucocorticoids, steroids cause adrenal suppression, hyperglycemia, poor wound healing. Biologic agents increase infection risk.
What about systemic lupus erythematosus, SLE?
Lupus is known for affecting multiple systems. Perioperative concerns often include potential renal involvement, lupus nephritis, hematologic issues, anemia, thrombocytopenia, leukopenia, serositis, inflammation of lining surfaces, and an increased risk of thrombosis, DVTPE, especially if antiphospholipid antibodies are present.
And ankylosing spondylitis, AS.
AS primarily affects the spine and sacroiliac joints, leading to progressive inflammation, fusion, and immobility, often resulting in a rigid kyphotic bamboo spine.
Making anesthesia hard.
Extremely problematic. The rigid cervical spine can make neck extension for laryngoscopy impossible. Limited chest wall expansion can impair breathing. TMJ involvement can limit mouth opening. General anesthesia often requires advanced airway techniques like awake fiber optic intubation or even an elective awake tracheostomy. Sedation is generally contraindicated due to the high risk of airway obstruction.
Wow. Okay, immunodeficiencies, patients prone to infection.
Yes, deficiencies in either cell-mediated immunity, T cells, or humoral immunity, B cells antibodies, predispose patients to infections. This includes primary immunodeficiencies, genetic, and secondary ones.
Like HIV/AIDS.
HIV/AIDS is a major example of acquired immunodeficiency. It involves the progressive destruction of CD4 helper T cells by the human immunodeficiency virus.
Treatment has improved.
Dramatically. The advent of highly active antiretroviral treatment, HAART, has transformed HIV from a fatal disease to a chronic manageable condition for many, significantly reducing morbidity and mortality.
Perioperative management.
Involves assessing the patient's current immune status, CD4 count, viral load, ensuring they continue their HAART regimen, and considering prophylaxis against opportunistic infections, like pneumocystis jirovecii pneumonia, PCP, if the CD4 count is low, typically 200 cells or more.
Other immunodeficiencies. Missing spleen.
Yes, patients who have had their spleen removed, asplenia, are at lifelong increased risk for overwhelming sepsis from encapsulated bacteria like Streptococcus pneumonia, Haemophilus influenza, Neisseria meningitis, and should be appropriately vaccinated.
Generally immunosuppressed patients.
Anyone on chronic immunosuppressive agents, for example, transplant patients, those on high-dose steroids or biologics for autoimmune disease, faces risks of poor wound healing and opportunistic or overwhelming infections perioperatively.
Okay. Substance abuse. Important to identify.
Absolutely. Distinguishing between abuse and dependence is critical for anticipating potential perioperative issues, especially withdrawal syndromes.
Alcohol withdrawal.
Can be life-threatening. It can progress from tremors and anxiety to seizures and delirium tremens, DTs. A severe syndrome, usually occurring 2 to 4 days after cessation, characterized by confusion, agitation, hallucinations, autonomic hyperactivity, tachycardia, hypertension, fever, sweating, high mortality if untreated. The CAGE questionnaire is a simple screening tool for alcohol abuse. Cut down, annoyed, guilty, eye-opener. 2 or more positive answers suggest high likelihood of abuse dependence.
Management.
Requires proactive management, usually with benzodiazepines like chlordiazepoxide or lorazepam, given on a symptom-triggered or scheduled basis to prevent severe withdrawal. Thiamine supplementation is also crucial to prevent Wernicke's encephalopathy.
What about opioid abusers or those on chronic opioids for pain?
They often have significant tolerance and may require much larger doses of opioids for adequate perioperative pain control due to pharmacodynamic tolerance and sometimes induced liver enzymes speeding metabolism. Managing their pain effectively without triggering withdrawal or causing respiratory depression requires careful planning.
Okay. Obesity. Measured by BMI.
Yes, body mass index, BMI, is the standard measure. Weight in kg, height in mard. Surgical risks, particularly pulmonary and cardiovascular complications, increase significantly, almost exponentially, with increasing BMI, especially in the morbidly obese, BMI 40, or super obese, BMI 50.
Pulmonary issues are common.
Very common. Reduced functional residual capacity, FRC, increased work of breathing, rapid oxygen desaturation during apnea, like during intubation attempts, higher risk of atelectasis and pneumonia.
And sleep apnea.
Obstructive sleep apnea, OSA, is extremely frequent in obese patients and is an independent risk factor for difficult airway management, postoperative respiratory depression, hypertension, CAD, CHF, and CVA. Screening for OSA G-stop bang questionnaire is important.
Sedation challenges.
IV sedation can be particularly problematic for significantly obese patients, especially those with OSA, due to the high risk of airway obstruction and respiratory depression. Often requires more controlled settings or general anesthesia with a secure airway.
Postoperative care for obese patients.
Encouraged to rest with the head of the bed elevated to improve lung volumes. Early ambulation is key. Aggressive use of incentive spirometry. And DVT prophylaxis is usually mandatory due to increased risk.
Geriatric patients, older age itself isn't the main risk.
Correct. Advancing age itself is not necessarily a poor risk indicator, but the high prevalence of comorbidities in older adults is. Plus, normal physiologic changes of aging mean their organ systems have less reserve, and compensatory mechanisms are less robust to handle surgical stress.
Common complications in the elderly
Include atelectasis, pneumonia, myocardial infarction, MI, DVT, PE, congestive heart failure, CHF, arrhythmias, stroke, delirium, and altered mental status, postoperative cognitive dysfunction.
organ function declines.
Yes, pulmonary function, lung capacity, elasticity, and cardiac function, compliance, maximal heart rate, naturally declined with age. Renal function also decreases insidiously, even if creatinine seems normal, due to loss of muscle mass.
Detecting infection can be harder.
Critically, yes. Older patients may not mount a typical fever or white blood cell response to infection. A high index of suspicion is needed for subtle changes like new fatigue, confusion, or altered mental status as potential signs of infection or other complications.
And medication management.
Perioperative and post-operative medications should always be chosen carefully in geriatric patients, with dose reduction often being the rule rather than the exception, especially for sedatives, opioids, and drugs with anticholinergic effects, to avoid adverse effects like delirium or excessive sedation. Start low, go slow.
Pediatric patients, unique challenges.
Definitely. They're not just small adults. They present unique physiologic and anatomical challenges.
Like their airway.
Yes. Relatively larger tongues, smaller airways that are more funnel-shaped, higher larynx position, floppy epiglottis, all making intubation potentially different or more difficult. They also have smaller functional residual capacity and higher oxygen consumption, leading to rapid desaturation.
Cardiovascular differences.
Infants and young children rely primarily on heart rate, not stroke volume, to increase their cardiac output. Bradycardia, slow heart rate, is often a sign of hypoxia and is poorly tolerated.
Fluids and drugs.
Require meticulous weight-based fluid administration and drug dosing. Their metabolic rates are different. Certain drugs commonly used in adults, like aspirin, risk of Ray's syndrome, tetracyclines, or codeine, may be avoided or used differently in children.
Okay, last one. Pregnancy. Big physiological changes.
Massive maternal physiologic changes occur during pregnancy to support the fetus. Increased cardiac output, increased heart rate, increased blood volume, but relative hemodilution causing physiologic anemia, increased minute ventilation, breathing faster, deeper.
Physical changes, the uterus.
The enlarging gravid uterus can compress the inferior vena cava when the mother lies flat on her back, supine hypotension syndrome, reducing venous return to the heart. So positioning requires a left lateral tilt during surgery, especially later in pregnancy.
Anesthesia considerations.
Delayed gastric emptying and decreased lower esophageal sphincter tone increase the risk of aspiration of stomach contents during induction of general anesthesia. Rapid sequence induction with cricoid pressure is often standard. Pregnant patients are also considered to have a potentially more difficult airway due to swelling.
Specific pregnancy complications.
Conditions like preeclampsia, hypertension, proteinuria, edema, eclampsia, preeclampsia with seizures, and HELLP syndrome, hemolysis, elevated liver enzymes, low platelets, are serious obstetric emergencies that require immediate consultation and often urgent delivery.
What about drugs crossing the placenta?
A major concern. Essentially, any drug administered to the mother can cross the placenta and potentially affect the fetus.
FDA categories.
The FDA drug classification in pregnancy, categories A, B, C, D, X, was historically used to guide drug choice based on risk evidence. Class A was safest, Class X clearly contraindicated. While this system has been replaced by newer labeling rules, the principle remains. Choose drugs with the best safety profile and avoid unnecessary medications.
And after birth, breastfeeding.
Yes, important to remember that many maternal drugs can also be excreted into breast milk and affect the nursing infant. Drug choices may need to consider safety during lactation as well. Outro.
So, after covering all that ground, what does this all mean for you, the listener? We've really unpacked a vast, complex landscape of medical conditions and their profound implications for surgical care.
Yeah, it's a lot to consider.
It's clear that successful surgery isn't just about the skill in the operating room itself. It's truly the meticulous, often invisible orchestration of a patient's entire health journey before, during, and after the procedure.
If we connect this to the bigger picture, this whole process, the comprehensive preoperative assessment, it's like an intricate dance. It involved gathering crucial information, understanding all those underlying risks we talked about, and proactively tailoring management strategies for each individual.
A personalized plan.
Exactly. It really underscores that optimal patient outcomes, safety, recovery, success, are the direct result of deep medical insight and proactive, careful planning. It's about turning potential vulnerabilities into areas of strength and safety.
So, consider the next time you or someone you know faces a surgical procedure, how understanding the comprehensive nature of this preoperative deep dive can empower you.
Knowledge is power here.
It's not just about what happens in the operating room, but everything that happens before to ensure the best possible outcome. This knowledge hopefully makes you a more informed and maybe less anxious participant in your own healthcare journey.